You've probably heard of GERD, right? Gastroesophageal reflux disease. It's a huge deal. We're talking up to a third of all adults deal with it, and it's one of the top reasons people go see their doctor. But it's so much more than just a little heartburn. So today, let's explore this really common but pretty complex condition, from that first burning feeling all the way to finding relief. You know that feeling, that burn in your chest after a big meal? Or maybe for you, it's a weird tickle or a cough in your throat that just will not go away. For millions of people, these aren't just one-off annoyances. They're signs of a chronic problem. So how do you know when it stops being a minor issue and starts being something you need to take seriously? That is the question we are digging into right now.
So, to really get a handle on GERD, we've got to look under the hood, so to speak. What's actually physically happening inside your body when you feel that burn? Let's break down the basic mechanics of reflux.
Okay, so picture this. At the very bottom of your esophagus, you've got this little muscular ring. It's called the lower esophageal sphincter, or LES for short. Its job is super simple. Open up to let food into your stomach, and then slam shut to keep all that stomach stuff, we're talking powerful acid, digestive enzymes, the whole shebang, from coming back up. GERD is what happens when that little valve, that barrier, starts to fail.
Now this is where it gets really interesting. Reflux isn't a one-size-fits-all problem. You've got your classic GERD, right? That's the one that gives you that signature heartburn and regurgitation right in your chest. But, and this is a big but, sometimes that reflux makes it all the way up into your throat and your voice box. That's a whole different beast, called laryngopharyngeal reflux, or LPR. Think hoarseness, a chronic cough, constantly clearing your throat. And why does this matter so much? Because people with LPR often think they have allergies or a cold that won't quit, and they end up going down a totally wrong path for treatment.
So the big question is, why does this valve, this LES, go on the fritz? Well, there are a few main culprits. Sometimes it just randomly relaxes when it shouldn't. Doctors call these TLSRs. Other times, the muscle itself is just kind of weak. It doesn't have enough pressure to stay shut. And then you have something called a hiatal hernia. That's where a piece of your stomach actually pushes up through your diaphragm, messing up the whole barrier system. Oh, and of course, extra pressure, like from obesity, can literally just force that valve open.
All right, so with all these different symptoms and causes, how on earth does the doctor figure out what's really going on? Let's walk through the typical diagnostic journey a patient might take.
This chart here really lays out the standard game plan. It all starts with you and your symptoms. If they're screaming classic GERD, your doctor might say, hey, let's try an 8-week course of a medication called a PPI. If that works and you feel better, great, we've probably found the problem. But if you only get a little bit of relief or the symptoms come roaring back, that's when it's time to dig deeper with more tests.
And when it comes to those tests, there are two big ones, the upper endoscopy and reflux monitoring. The endoscopy, or EGD, is pretty straightforward. A doctor uses a tiny camera to take a direct look at the lining of your esophagus to see if there's any visible damage from the acid. But reflux monitoring is different. It's a test that lasts anywhere from 24 to 96 hours, and it actually measures how much and how often stuff is coming back up from your stomach. It can even tell if it's acid or something else causing your symptoms.
And this is a really, really important point. You can have an endoscopy that looks perfectly normal, but still be having terrible symptom-causing reflux. This is exactly why that reflux monitoring is so critical. It's the test that can diagnose what we call non-erosive reflux disease and prove, once and for all, that what you're feeling is actually tied to a reflux event.
Okay, so you've got the diagnosis. Now what? Where do you even start with treatment? Well, it almost always begins with the basics, some really powerful lifestyle changes, and the most common type of medication. This is your first line of defense.
Seriously, do not sleep on the power of these lifestyle tweaks. The evidence is solid. Weight loss, if you're overweight, can make a huge difference. Quitting smoking helps big time. And even simple things like propping up the head of your bed, not eating for a few hours before you lie down, and figuring out your personal trigger foods, you know, the spicy stuff, the fatty foods, can dramatically cut down on how often you get reflux.
Now, this is a super simple but kind of mind-blowing tip. Just because of the way your stomach is shaped, sleeping on your left side actually keeps the opening to your esophagus above the acid level in your stomach. It's been shown to seriously reduce nighttime reflux. But flip over to your right side or lie on your back, and you could be making things a whole lot worse.
So what happens when those lifestyle changes just aren't cutting it? That's when doctors usually turn to the go-to medication class for GERD,
proton pump inhibitors, or PPIs. They work by shutting down the tiny little pumps in your stomach lining that produce acid. By doing that, they drastically reduce the amount of acid that can cause trouble. When it comes to healing damage and getting symptoms under control, pretty much every guideline agrees these are the most effective meds we have.
But, and there's always a but, isn't there? As great as PPIs can be, using them for the long haul has become a huge topic of conversation, both for patients and for doctors. So let's get into it. Let's unpack the great PPI debate.
To get this right, let's go straight to the source. This is from the 2022 guidelines from the American College of Gastroenterology. They say, look, PPIs are the best medical treatment we have. And while a lot of studies have suggested scary links to other problems, the really high-quality research has found that PPIs don't significantly increase the risk for most of those things, like fractures or dementia. The one exception they point out is a slightly higher risk of intestinal infections.
So you might be wondering, where did all these worries come from in the first place? Well, they mostly come from what are called observational studies. These studies can find a link, an association, between two things, but they can't prove that one caused the other. So they've seen these associations with things like bone fractures and vitamin deficiencies. But the key takeaway from the experts is this: the decision to use a PPI should be about whether you actually need it for your reflux, not about being scared of these unproven risks.
And because of all this debate, there's a big push for what's called PPI stewardship. Basically, it just means doctors should regularly check in and ask, hey, do you still really need to be on this? And if the answer is maybe not, they'll have a structured plan to deprescribe. That could mean lowering the dose from twice a day to once a day, or trying to taper off it completely. The goal might be to switch to just taking it on demand, only when your symptoms actually pop up.
But what about people who either don't get enough relief from PPIs, have side effects, or just plain don't want to be on medication for the rest of their lives? For them, there are procedures designed to go in and physically fix that leaky valve. And these procedures really fall into two main buckets: endoscopic therapies, which are done through your mouth with no cuts, and laparoscopic surgery, which uses a few small incisions in your belly. The big thing to understand here is the trade-offs. The endoscopic options are way less invasive and tend to have a lower risk of side effects like bloating. But the surgical route is better if you have a larger hiatal hernia that needs to be repaired.
These endoscopic therapies are pretty cool. They're like a middle ground between meds and major surgery. You've got options like the TIF procedure, which basically builds a new valve from the inside using little fasteners. There's Stretta, which uses radio frequency. Think of it as gentle heat to strengthen the valve muscle. And then there are newer techniques like ARMS, where a tiny bit of tissue is removed, and as it heals, it scars and tightens up the whole area.
And this right here gives you a peek at the tech they use. This is the device for that TIF procedure, called the S-Affix. It's pretty amazing. It goes down through the mouth, so no cuts on the outside. It lets the doctor grab a bit of the stomach, fold it over, and use those fasteners to create a brand new reinforced valve.
Now, when it comes to surgery, the gold standard for a long time has been the laparoscopic Nissen fundoplication. That's a mouthful, I know, but what it means is the surgeon takes the top part of your stomach and wraps it all the way around the bottom of your esophagus. This creates a really effective new anti-reflux valve. It's definitely more invasive, but it has an incredible track record of success.
So when you step back and look at it, you've got lifestyle changes, you've got powerful medications, and you've got these incredible procedures. The point isn't that one of these is the best for everyone, it's that there's a whole range of options. The real question then becomes, what's the right mix for your unique path to relief?
At the end of the day, getting a handle on GERD is all about teamwork. It's a partnership between you and your doctor. It's about figuring out what's really causing your reflux, talking through the pros and cons of every treatment, and coming up with a personalized game plan that lets you feel like yourself again. So the most important next step, it's always having that open, informed conversation with your healthcare provider.